So, good evening, everyone. I'm Dr. Netra. I'm doing my DRMD residency in Manipal Hospital, Bangalore, under Dr. Karthik Nagesh. I'll be starting the OSCE presentation for today's session. So, coming to case number one, we have a primary gravid mother who came with leak PV and severe oligohydramnios. She came in labor at 31 weeks of gestation. Antenatal steroids would not be given as she came in labor. Emergency LSCS was done in view of non-reassuring NST. Baby did well, baby cried at birth. First discussion will be how do we do cord management in this baby who is born at 31 weeks who cried at birth?
So,
Can anyone take this question?
yeah, Dr. Pragnya, please go ahead.
So we can do delayed cord clamping in the situation as the baby has cried and everything is normal. Then we can go ahead with a delayed
Okay.
delayed clamp cord.
Good. So it's more important, as we discussed last week, for a premature baby, as they have relatively lower circulating volume and they are at risk of hemodynamic stress as well. So we can go to the next point.
Yes, sir. So the answer rightly said was
I
yes,
think
we
we'll
can go
finish
ahead
all the
with.
4 points, so rather than going back and forth.
Okay, fine, sir. So coming to the second question.
No, I mean, you have more points in the first question, right?
Yes, sir. Yes.
Okay.
No, the first question has 4 sub-questions. There are 3 more questions left, sir.
So you're going to go step by step for each question. Okay, then you proceed as you want. It's fine.
Yes, sir.
I thought
Yes,
you were
sir.
going to put the 4 questions first
I
and
want
then
to
discuss the answers. Okay.
no, sir. One by one. One question I'll put, and then we'll discuss regarding that question. Should we do this
You
way, or
can
should
dis-
I take the second
No, you
question,
can
sir?
discuss the answer if you have put the slides that way, because when we shared it wasn't clear. Okay, you go ahead.
Okay. Okay, sir. So the answer was clear. Yes, we can do delayed cord clamping in this baby who is born at 31 weeks of gestation. The recent NRP says vigorous term and preterm babies, delayed cord clamping should be done at least for 30 to 60 seconds. But then it also mentioned that the babies who are born at less than 32 weeks should be delivered in polythene plastic wraps, and DCC should be done if they are vigorous. NRP does not mention the lower gestation age cutoff for this. So there is ILCOD recommendation, which is updated in 2023. This gives the gestation age based cutoff for the delayed cord clamping. These recommendations are based on systemic review and pairwise meta-analysis with individual participant data on cord management in preterm babies. This was based on the RCTs, which compared different umbilical cord management strategies. 3 interventions were studied in the analysis: delayed cord clamping, immediate cord clamping, and umbilical cord milking. So the comparison was made between DCC, ICC, umbilical cord milking, and DCC, umbilical cord milking versus ICC. And the outcomes were studied. The outcomes were short-term and long-term. The short-term outcomes studied were mortality, transfusion requirement, ROP, DPD, MEC, and IBA. So based on the analysis, it was observed that babies who were managed by DCC did better in short-term outcomes as well as long-term outcomes, especially the immediate short-term outcomes like mortality and transfusion requirement, as compared to the babies who were managed by umbilical cord milking and immediate cord clamping. So DCC was more favored management as compared to umbilical cord management and ICC. Between the second two groups, that is umbilical cord milking and immediate cord clamping, the results were favoring umbilical cord milking in terms of short-term management like mortality and transfusion requirement. But the other morbidities like ROP, BPD, NEC, and IVH were not different in the two groups. So the recommendation was made that for any given gestational age, DCC should be preferred over umbilical cord milking, which should in turn be preferred over immediate cord clamping. So these are the recommendations given. Any baby who is born less than 37 weeks and not requiring any resuscitation should be managed by DCC at least for 60 seconds. This has strong recommendation with high certainty of evidence. The second group, that is 28 to 37 weeks, DCC is still preferred, but if for some reason we are not able to do any DCC For example, if the baby is not vigorous, the baby has very severe respiratory distress, then BCC should be deferred and at least umbilical cord milking should be done. This improves the hematological outcomes of these babies. And the last group study, that is less than 28 weeks, the recommendation is only for intact cord milking because the number of studies which compared BCC and immediate cord clamping versus intact cord milking were less. So the recommendation was possible only for intact cord milking, that too with weak grade of recommendation and low certainty. So to summarize, all babies less than 37 weeks, irrespective of gestational age, BCC is better. Between 28 to 36 weeks, BCC is still
Netra,
better.
just 1 second. For the less
Yes,
than
sir.
28 weeks, cord milking is not recommended. It should be delayed cord clamping only. The intact cord milking not recommended is based on Dr. Katharia's study. So they should do only delayed
Okay.
cord clamping. So maybe this is a
Okay.
typo. We will double check that. It's fine. And there was a
Yes.
question from Jenny on what if the baby doesn't cry. So as we discussed last time, I mean, if the extreme premature babies, we don't expect them to cry. So if the baby has a good cord pulsation, request the obstetric team to be familiar with feeling the cord pulsation. And if the cord pulsation is good, you still wait for the 30 to 60 seconds in the small premature babies as well who don't cry. This is different from fetal distress asphyxia setting. There, the recommendation is consider cord milking if it's possible, but delayed cord clamping is not recommended in asphyxia setting. So asphyxia setting, not crying is different from a premature baby who is not crying because of their neurologic immaturity. So we should educate our obstetric team to differentiate that. The cord pulsation is a good indicator. If there is fetal bradycardia, it would show it will be a sign of fetal intolerance and so on. So that is one point. And Dr. Pragnya had asked to share this. Jyoti usually shares the slides, but the article part, I think you have the AAP recommendation as well, which came up. So we can
Yes, sir.
discuss that. Okay, go ahead with the
Okay.
next point.
Okay. Let's go to the second question of the scenario. So the baby cried at birth and we did the delayed cord clamping for 60 seconds. Now the baby has developed labored breathing at 3 minutes of life. What is the recommended respiratory support which is given at this age? And what is the FiO2 and peak to be started with? Can anyone take the question?
Dr. Talib, you wanted to answer earlier. You want to answer this one?
Yes, I will start with the PIP or an IPPV.
PEEP, you mean? And what FiO2 do you start with?
I will start with 30.
Okay, that's when there's a premature baby, you would start with 30. Dr. Pragnya, was it you who was trying to speak?
Sir, it is
And
answered.
I
We will start with PEEP with 5
increase
and
according
and
to
FiO2 30%.
age, age of the baby, and I will increase gradually.
Okay.
I
Could
think
be
in
better
this
if we
case,
speak one at a
acceptable
time so we
saturation
don't
will be
overlap.
around 75, 8.
Okay, let's speak one at a time so that there is no overlap of the voices. Okay, go on, Dr. Netra.
Yes. So the answer was correct. We have to start CPAP with the TP's resuscitator, starting at the FiO2 of 30% and PEEP of 5 mmHg with a good seal of face mask. As the baby in this scenario is 31 weaker, it is recommended to start between 21 to 30% FiO2 and PEEP of 5 mmHg. Let's
Okay,
go
so what will be
to
the
the second
primary
question.
determinant, Dr. Netra, for whether to start this baby on CPAP or to start IPPV?
So this baby has a labored breathing. You would start PPV if the baby had poor respiratory efforts or heart rate of less than 100, even with the initial steps. So since the baby has heart rate of more than 100 and the good efforts, and the baby has labored breathing, we would like to start with the CPAP with the TP's resuscitator, sir.
Okay, so labored breathing, how do you define?
So this baby is of 31 weeks gestation
No,
age.
I mean to
We
say, when
can
you say, you're not talking of respiratory distress here, isn't it? You're talking of labored breathing. So how
respiratory
would you
distress.
differentiate labored breathing, which is due to poor effort, from labored breathing? So you have to say that you're looking at the effort of the baby. So if the
Yes.
effort is good, the baby can have labored breathing with gasping is also called as labored breathing, but it's not a regular effort. So if it looks like baby is in distress, you would start CPAP. If the baby has poor effort, you would start IPPV. Okay. So the word
Yes, sir.
labored breathing is usually non-specific. You have to categorize it. Like you'll come later with the Downe score, so we'll discuss that as well. So labored breathing can mean gasping as well. Okay. The effort of breathing is increased, but it can be distress where you would consider CPAP. In this situation, I agree with you. I mean, CPAP is fine, provided the baby tolerates. If you feel the heart rate is going down with the CPAP or the baby is worsening, you can move on to IPPV. Okay,
sir.
continue.
Sure. So going to the third question of the first scenario. So we started the baby on CPAP and shifted to NICU with a trunk incubator and CPAP on C2. In the NICU, we observed the baby. During observation, the respiratory distress was noticed to be increasing while on CPAP. The Silverman Anderson score at this point was 7/10 with a FOUT of 50%. So we did an X-ray to know the underlying cause. This was the X-ray taken. Can anyone interpret this X-ray?
I think Dr. Shefali is speaking. Please, others, mute yourselves. Dr. Shefali, please speak.
The X-ray is showing severe RDS, sir, and we should give surfactant therapy for this child for specific treatment, sir.
Okay, just for a quick overview of X-ray review, can you just read this X-ray?
Sir, X-ray is well centralized, well exposed, and it's showing around 7 intercostal spaces, and full reticular granular patterns are there, and it's covering entire lung shadow, so it suggests severe RDS, sir.
Is it a AP film or a PA film?
Sir, AP film.
In a newborn, where is the plate?
Plate is on the back, sir.
Okay. And this is almost like a whiteout lung, isn't it? As someone has commented in the group as well. So the reticular granularity is so dense that it becomes a whiteout. And you mentioned about the positioning. So ideally, we should have a little more of the neck and things covered as well. The clavicle is not visible here, and we are assuming it's well positioned. But you need to see the clavicle as well to comment, and also the neck is slightly turned probably. Any lines in this baby? Lines or tubes?
No, sir.
Okay. So ideally, we should have a feeding
Visible.
tube as soon as the baby is admitted on CPAP.
Not visible.
So, yeah, in this case, it's not visible. And some units are still using the feeding tubes, which are not fully radio opaque. So that's another thing to look at, because the feeding tube position is very important for two reasons: for decompression of the stomach, as well as to make sure that the tube is decompressing. And if you do start, we often feed the baby. So if you're starting tube feeds, there is a risk of aspiration if it's a high tube. And we will go on to Dr. Neelima. Do you want to comment on the surfactant therapy in this baby? Would you go for Ensure or would you go for Lisa? What would you consider? Or would you keep the baby intubated? Dr. Neelima, you can unmute yourself.
Sir, we can keep the baby on the CPAP only,
Okay.
and can give the Lisa.
Okay, either Lisa or Ensure if it is done properly.
We can give the Ensure and keep the baby on CPAP only.
Okay, if your unit, as Dr. Karthik was explaining last time, you can consider Ensure if your unit is fully versed with that. Dr. Karthik, you want to comment on the Lisa versus Ensure again?
See, as I mentioned earlier also, Lisa takes a little learning curve and it is requiring a little more practice. But most of the times, you would not go very much wrong if you do Ensure. But more and more towards more of your training or something, should practice more of Lisa. That's what I would say. It's much more easier, and many of my residents have seen Lisa work so smoothly and nicely. It's probably, I think, much more easier to do once you get the knack of doing that.
Yes, Dr. Ranganatha said depends on the unit protocol. And as Dr. Karthik said, you always need to make a start. So think about it, think actively. And during the day, for example, if all of you are around, start doing the Lisa. So you can point out errors and correct each other. During the night, you can stick with Ensure if you're comfortable. But remember that the ideal way of Ensure is to give intubate, surfactant, and extubate. Don't keep the baby with the tube in. So that is where most of us go wrong. And one of the questions is grade 3 versus grade 4. So you can still see some lung marking. So this would be grade 3. And the volume is not too bad. Grade 4 would be more closed down, but it's borderline. Grade 3 to 4, you can say. Dr. Priyanka, please go ahead. Unmute yourself and speak. Dr. Priyanka, can you unmute?
Yes, sir. Am I audible, sir?
Yeah, please go ahead.
Sir, I was just saying if we are using ensure that whatever volume we have made by CPAP, even after half an hour, that will be lost. So I think it will be better to use Lisa in this case.
See, you are going to drip the surfactant into the airway in any case, and you know that we have the nasal cannula for CPAP in most of the units now, RAM cannula or similar. So you are going to consider your continue your surfactant treatment, and this is an already recruited lung on CPAP. FiO2 is high, and you decided to give the surfactant. So, you know the surfactant delivery is quicker. The process is quicker with Ensure as well if you are experienced intubator, and 1 to 2 aliquots depending on the volume you are giving and whether you are giving Curacao or Cervanta. So the closure of the lung volume matters more in the initial stage before the lung is recruited if you're doing it in the labor room. Of course, the studies are showing a better evidence with Lisa compared to Ensure, and part of the reason is, as Dr. Karthik was mentioning in his earlier talk, I mean, you're welcome to watch the recording of his lecture on surfactant therapy as well. It will come later in the module as well. So basically, if Ensure previously the definition was up to 2 hours, you can keep the baby intubated, and any time of length with positive breaths through the tube is not good for the baby. That's why I keep stressing that if you are doing Ensure and you decide to extubate the baby based on the overall picture, remove the tube quickly. So the effect will not be much different in these cases. So you don't need to be scared to use Ensure. And from the first batch, I mean, one of the colleagues had just shared that he did his first Lisa in his unit last week. He had shared the X-rays in the other group. I can post it in your group as well. So there is always a start. I mean, if you have the catheter, if you don't have the catheter, you have the feeding tube, but you do need the McGill's forceps if you're using a feeding tube. You need some expertise. In the tiniest babies, it's not technically easy to use a McGill's forceps in the small mouth of the baby. So you have to look at all those factors. Dr. Ranganath, Dr. Karthik said all of you are very expert at doing it. Do you want to share your feedback?
Hi, sir. Uh, we are learning, sir. The other day we did for a 24-weeker. In fact, Karthik sir himself did. So I'm like not familiar to Lisa myself. So still learning. We are doing it, sir. Ensure I'm more comfortable, but Lisa, frankly telling, I need to learn little bit also.
Yes, Dr. Deepika, I also agree that Lisa needs expertise, especially in the tiniest babies. And obviously, you don't need to be bogged down by it, but don't have a mind block either. I mean, if you can't do it immediately, don't worry. Ensure with the tube removed immediately works well. But if you have any concerns, you can go ahead. So we'll move to so in this baby, we all agree that you would give surfactant and either Lisa or Ensure and you'd extubate the baby. Go ahead, Dr. Netra.
Yes, sir.
Next slide, yeah.
Okay, yeah. So homogeneous white lungs with air bronchograms, history of RDS, and as all suggested, it is a surfactant therapy by Lisa or Ensure. Moving on to the second scenario. So there is a 40-week-old boy
1
baby.
second, Jyoti, is Dr. Narasimha joining or what's the
there is one participant called VL Narasimha Rao. I don't know whether he's the same person.
Yes, same person.
Same person? Okay, yeah, then he has joined.
Okay, so Netra will finish in 10 minutes for this case.
Sure,
so
sir,
that
sure.
Narasimha can present as well. Okay.
Sure, sir. So we have a 40-week. Okay. So there is a 40-week boy baby delivered to a primary gravida mother by emergency LSCS in view of non-progression of labor. Baby cried at birth and DCC was done, but developed respiratory distress at 3 minutes of birth with a respiratory rate of 70 per minute, mild retractions, cyanosis, grunting which was audible without stethoscope, and with good bilateral air entry. Calculate the Downe score of this baby.
So I think Dr. Dharini can answer this. Dr. Dharini, can you please unmute yourself and speak?
Okay. So I'm audible?
Yeah, you're audible.
Yes.
Go ahead.
So Downe respiratory rate is 70 to 1. Child is having cyanosis in second 1, and retractions are there again 1, and grunting is there without certificate, and bilateral air entry is good to 0. So and since
Okay, Dr. Netra, you can go to the
Yes, sir. Yes, sir. So the scores for respiratory, cyanosis, retractions, and grunting are 1, and audible grunting without stethoscope is 2, and their entry was cleared, so 0. So the total score comes up to 5 by 10. So the baby is in respiratory distress. as per the classification and interpretation. So moving on to the next
Just
question, how do
just
you
a big
manage?
point about the use of scores for respiratory distress. Obviously, some of you are using it routinely, some of you may not be applying it, but if you have a big team and you have a communication over phone, for example, to discuss, this makes you having an objective approach. In the previous case, you mentioned Silverman scoring of 7, and that's because this was a premature baby with more retraction. So if you have a premature baby with the RDS setting, the Silverman score is better. And Downe score applies to both term and premature babies. So, Dr.
Yes.
Dharini, it was not very clear. Your audio was not very clear, but it's okay. So, if you are not using it, if you are a one-man army and you are just assessing and making the decisions yourself, educate your nurses on this, so that if you get a call from them and they describe this and they give you a score, it becomes easier for you to assess. If you are a bigger team and you are speaking to your senior over the phone, for example, again, document the score and discuss the score so it's more objective. And it's not definitive that if you have a certain score, you need a certain action. You need to overall look at the overall picture. You need to look at the FiO2. You need to look at the baby's condition, the chest X-ray. So it's a rough guide. Some of you may say more than 7 needs intubation, or 4 to 6 CPAP is enough, and so on, but it depends on the baby. So don't be dogmatic about that part of it. So let's move on. Continue.
Okay, sir. So the baby is in respiratory distress. The second part of the question, how do you manage this case in the delivery room? A baby with respiratory distress who is term baby, how do you manage this case?
So Dr. Ranganath has already mentioned adequate respiratory support, delivery room CPAP. And if you are using PPV, you should use PEEP. So that means don't use the bag, use the TP's device. Okay.
Okay. Yes, sir. So start with the CPAP, TPs with FiO2 of 21% and PEEP of 5 with a good seal, and adjust the FiO2 to meet the target saturation as per the Dawson's charts. So moving on to the third question of the scenario. So now you have started CPAP at 3 minutes of life with a PEEP of 5 and 21% FiO2. Cyanosis is improving clinically, but the pulse oximetry shows saturation record of 65% at 5 minutes of life. What is the next step you will take in the respiratory management of this case?
Dr. Sai Pratap, you had a question on the use of high flow. Do you want to tell your opinion and then answer this question as well? And then we will discuss. Please unmute yourself.
Sir, yes, sir. Actually, that is term baby. Usual causes are TTNB in this type of child. So but distress is more moderate respiratory distress. But in terms of TTNB with term baby, it's consideration of high flow in HFNC.
So here the question is in the labor room. Obviously, in the labor room,
Yes,
you're mostly using the TP's device where you'd give CPAP. But once you come to the NICU, so we have 2 categories of babies where you expect the disease to be evolving, where the distress could increase and you want to titrate the PEEP. In those cases, it's better to go for CPAP. In high flow, you have a little limitation. You can go up to 8 liters flow in the term babies, but still the PEEP delivered is not measured, and the ability to manage them with the higher pressure is not that controlled. So if you think the disease is evolving or worsening, if your oxygen requirement is high or the baby is a significantly small baby, go for CPAP or NIPPV. But if the baby is relatively stable TTN and you expect the baby will stabilize within 1 to 2 days and you don't expect immediately to worsen, you can consider high flow. So the answer is you can consider, but where the disease is increasing in severity, I wouldn't consider high flow. So when you're shifting to the NICU, you can assess your prediction. Most of the time, you can look at the distress, the oxygen requirement, and make a decision. Of course, most of the units now are using the same circuit for both options. If you have the bubble CPAP, you can use the same circuit, slightly modified to use it for high flow as well. So you don't need to waste a circuit for that. It's just switching them. You can use mass CPAP with the Neoco, for example, when you're switching them. What is the recommended interface for CPAP administration during transport? So again, it depends on if you have a transport ventilator and you can use a RAM cannula connected to it. If you are moving in the open care system, for example, you can have the gas open and the TP's device can continue to provide your CPAP. Depending on the distance, how you are moving, be careful not to tread on your colleague's toe if they are holding the mask, because it can be really painful to have a warmer or an incubator climbing on you. It's easier to move holding on a warmer than an incubator because the back position. So remember that ergonomics and everything is important for the supporting team as well. So the best solution, if you have a transport incubator, ram cannula can be used to shift the baby, or even a CPAP setup can be set before you move. But if you are moving in a warmer, it's acceptable with the TP CPAP as well. So the pulse oximeter part, I mean, Dr. Sai Pratap, do you want to comment on that?
Yes, sir. Even at 5 minutes, saturation is 65% means, which is target lower than targeted range. Usually target is 80 to 85 range. And at the same time, cyanosis is improving, but saturation is not achieved. So first thing Dr. Rangnath sir mentioned clearly, it is good also. Pulse oximetry connected accurately or not. Second thing, if connected accurately, then go with increase FiO2, because we are connected in the 21%, which is lowest level, but we can go up to 30% minimum FiO2. Still, it is not improving, then we have considered up to PEEP increasing also, because it is PEEP also 5 mmHg, and the distress is moderate respiratory distress.
Okay. Dr. Deepika, do you want to differentiate the pre and post ductal saturation? What is the difference between the two? And in newborns, what saturation are you using? Please unmute yourself, Dr. Deepika.
Sorry, sir, I didn't get your question.
No, can you explain the difference between pre and post ductal saturation? And in the labor room, which one are you looking for?
Sir, in the labor room, we'll be definitely looking for the postductal saturation, and we have to check for. Sorry.
Which hand are you looking at?
For preductal saturation, I'll be choosing the right upper arm, and the postductal saturation, I'll be choosing any of the lower arms, lower limbs.
In the labor room, what did you say?
In the labor room, we are going to look for the preductal saturation, sir.
Preductal, yeah. Initially, you said postductal, but that was a slip of the tongue. Yeah. Go ahead.
Sorry.
You are looking for the preductal. Yeah, that's because you are looking at the optimal saturation to the brain, right?
Yes, okay. Yes.
And we know the PDA is open and the baby is still having pulmonary hypertension evolving. So it's in the adapting phase. So you don't want to look at the postductal to titrate your oxygen. You may overdo it. So Dr. Narasimha's presentation will discuss a lot on oxygenation. So we will not spend too much time on this part. Can you move on, Dr. Netra?
Yes, sir. Yes. So it was answered correctly. So the saturation target at 5 minutes of age was 80 to 85%. So we can increase the FiO2 to meet this saturation and then consider increasing the peaks. So next question, interpret the X-ray of this baby and give the diagnosis, the same baby.
Okay, Dr. Ishita didn't speak so far. Dr. Ishita, do you want to try? Please unmute yourself.
Yes, sir. This X-ray is well centralized. Exposure looks good, but there are heterogeneous opacities all over the lungs, especially on the. I mean, there is no marking here, but I assume on the right side there are more of heterogeneous opacities. So to interpret the X-ray, I would like to have a history, sir. If it is the same baby, it could be more of TTNB. There is sunburst appearance also, so it is more suggestive of TTNB.
Yes. So, I mean, this is the same baby. And yeah, proceed,
Yes.
Dr. Netra.
Yeah, so there is perihilar streaking with sunburst pattern with widened and fluid-filled interlobar fissure, suggestive of TTNB. So moving on to the third case scenario, should we continue, sir, or should we start with the second?
This is only one X-ray we are discussing, no? Yeah.
Yes, sir. Yes, only one X-ray. Yes. So third scenario, 36-week-old baby delivered in a private nursing home to a primary gravida mother, developed respiratory distress at 1 hour of flight, reached emergency room by private transport, was noticed to be having bradycardia with saturations of only 40 to 50%. Resuscitation done in the ER, intubated, heart rate improved to more than 100, but then the saturations were only 70 to 80% with 100% FiO2. Shifted to NICU with transport ventilator for post-resuscitation care, and the X-ray was taken. Interpret the X-ray and give the diagnosis.
Okay. Who wants to answer this? Dr. Jenny, do you want to answer? Can you unmute and speak? Okay.
Yeah. Yes, sir. Yeah, I think there's opacities in the right lower lung. So maybe it's suggestive for pneumonia.
Okay. I mean, it can be anything. So the baby has 82, obviously, and the positioning isn't great. Dr. Dharani, I wouldn't comment much on the egg on side because of the rotation, and it's quite early as well. This is the first X-ray. Baby has a UVC. What do you think about the UVC position, Dr. Jenny?
Yeah, I think It is too low. It should be right on the diaphragm.
So what would you do for this UVC?
I think I would like to pull it and not use it.
So you can try to reinsert another one around if the baby is still fresh, and you can try passing a larger one or with tight maneuvering, and keep this in situ and try. And if it doesn't work, you can pull it down to a low-lying UVC and go for a PICC line if the baby is sick and needs access. So Dr. Netra, please proceed.
Yes, sir. So there is ET in situ. This is chest X-ray AP view with good lung expansion, and with ET in situ with homogeneous white lung with air bronchogram suggestive of RDS, sir.
So as we said, this is very sick baby to start with. You're on 100% oxygen, not saturating well. So you consider this as a respiratory pathology. The X-ray quality isn't great, but you can see opacities in the lung. Of course, if the baby doesn't respond to your respiratory management, you would still do an echo quickly in these babies. And I agree that you need to consider heart disease as well. So, but you cannot interpret based on this positioning of the X-ray, because you can see the clavicle is rotated out. The
Yes,
left shoulder is down and the right shoulder is up. So it's not a good positioning. And the opacification is not that homogeneous, because you see more perihalar opacification. But you need to keep it differential diagnosis as well. Yeah. So with this, we will close. Yeah.
Okay. So this baby we recently handled, sir. So this baby we initially managed as RDS, and before managing as RDS, we did a bedside 2D echo. As you rightly said, cardiac pathology is still a possibility. It was ruled out, and then the diagnosis of RDS was made. Surfactant was given, sir.
Yes. Okay. So
thank you.
Thank you for this very nice presentation. You put in a lot of effort. We still have a few more OSCEs you prepared, which we will use for the future meeting.
Yes,
please, Dr. Karthik, go ahead.
Netra, thank you so much. It was a wonderful presentation. I just wanted to sensitize all the young students here that 36-weeker late preterm babies who are between 34 to 37 weeks, we do get severe RDS and sometimes PPHN in these babies. So if you have babies delivering like this, don't just leave them alone after resuscitation. You have to closely monitor for the first 4 to 6 hours. And this is unfortunately a problem which is arising of late. And many such babies are delivered, and general pediatricians also look after them. And many times they're left alone after delivery, and subsequently they go on to severe distress like this baby. This baby was referred to us from a town which is about 3 hours away from Bangalore. Luckily, the baby came and was, in fact, almost brought near dead. And thanks to our registrars like Ranganath and others who managed, Netra and others who managed this baby in the immediate thing, the child could get pulled out. So please keep this in mind. Thank you.
Excellent. Thank you, Dr. Karthik. And as he mentioned, PPHN physiology is in the background in every sick newborn. Remember that it's not a specific diagnosis. A baby is coming out of a PPHN state after birth, and anything that you do that is not right, or that happens to the baby, hypoxia, acidosis, hypothermia, sepsis, any of these can flip the baby into PPHN. And it doesn't mean that the baby who is well in the beginning may not go into PPHN. So you may have a mild RDS presentation, and the baby may suddenly deteriorate after a feed or something like that. Once a hypoxia happens due to the apnea or any episode of aspiration, the PPHN may come up, especially in IUGR babies or borderline term babies. This is quite common. And again, it's not always a single diagnosis. So in an infant of diabetic mother, you may have TTN, and it may be more severe than you think. It could be a RDS pathology in the background as well. So it's not absolute. There may be overlapping diagnosis. Any diagnosis can have infection overlapping. In a premature baby, PDA may start contributing after the second day or so if it's open and enlarging. So hemodynamics change a lot. It's always an evolving picture. Don't be stuck on a diagnosis. Look at the condition of the baby, manage the ventilation as per the baby's requirement. So once you make a setting change, doesn't mean you will be staying on that. Educate the team on what to look for. If you are intubated, look at the waveforms, look at the